for interpretation of the OCT. I have not a 20 minutes or 30 minutes atlas, but I will give you an overview how to handle the acquisition once you have performed. Well, as you all know, the OCT and the intravascular imaging provides incremental information, and since OCT has the much more precise resolution in comparison to the IVUS, of course, you have so many information that have to be interpreted. And if you're going to use OCT, the interpretation has to be performed, in my opinion, in 3 procedural steps. First of all, we have the pre-procedural assessment, where you have to look at the black morphology. Secondly, you have to go through the co-registration, and you have to determine the stent dimension. And thirdly, there is the procedural acquisition, where you have to decide whether your stent is expanded, well expanded, or malapposed, if you have any edge dissection, or is there any identification of mass or thrombus. So let's start with the pre-procedural assessment. First of all, for the interpretation of the black composition, we have to go for a systematic analysis of the OCT acquisition. First of all, you have to assess the backscattering. What does backscattering means? The term describes the reflection of light being reflected by the surface or an object, and if there is a good portion of light which is reflected by the surface of an object, so it appears bright, and in contrary, of course, it appears dark. The second term you have to learn is the attenuation or absorption. So the light is reflected or absorbed, and if there is a great weakening of the light, so the attenuation is high, and vice versa, it is low, as shown here in this picture. Well, the borders of an object can be sharp or even diffuse, as you can see here. And finally, we have the area of an object, which can also be homogeneous, like it is in this case here, or it can be heterogeneous and a calcified area, which I wanted to show you in a couple of minutes. So, well, if you look for the interpretation of a black, so it's very common to look first to the backscattering. If it's bright, then you have to interpret the attenuation. If the attenuation is low and your area of black is homogeneous, so there is a typical fibrotic plaque. And is the backscattering dark? And then you have to decide, well, whether the attenuation is low, if the area has sharp edges and the area is heterogeneous distributed, so there's a fibrocalcific plaque and a high attenuation with diffuse edges and homogeneous plaque structure. So this is a clear fibroatheroma here in OCT. Let's take a look again on the picture. So here you have a bright backscattering. Of course, there's some shadowing, which is caused by the blood, because blood has hemoglobin. Hemoglobin is 4 times hemoglobin binds 4 times iron, so you have the reflection with a shadowing behind the blood. So this is the reason why there's this shadowing. And nevertheless, you have a low attenuation in this part. The object appears homogeneous. That's a fibrotic plaque. Here in this picture, you have a dark backscattering in this area. There's a low attenuation of the light, and you have clear, sharp edges, so you can discriminate the object with an inhomogeneous area. This is a fibrocalcific plaque. This is very important to assess because this has some incremental to our decision how to handle with this plaque, because as you know from this nice publication, the arc of calcium is very important to assess. We all know if you have an arc greater than 270 degrees, so this is an independent predictor for under-expansion of your stent. So, of course, you have to handle this lesion very thoroughly and carefully. So that's not only the arc, but also the thickness of the plaque structure, the calcium structure. It's greater than 0.5, or if it's exceed more than 5 millimeter. So this is as well an independent predictor for under-expansion. So these are other examples for a fibrocalcific plaque structure. Again, in the upper panel, you can see the arc of 270 degrees with a thickness of the calcium more than 1 millimeter. And this is, of course, a risk for under-expansion. In contrary, you have here an arc which is not more than 180 degrees, and the thickness is below 0.5 millimeters. Here you can see the calcification is only 100 degrees or even smaller, 30 degrees. Of course, these lesions are not in the risk of under-expansion if you put in a stent there. So finally, the fibroateroma you can find in this picture again, the dark backscattering, which you can see here. It's a low attenuation of your light. We have this diffuse edges. You cannot make a border in of this object, and this is an inhomogeneous or homogeneous plaque structure resulting in a fibroateroma. So this is a clear fatty fibroateroma. I think it's important to characterize this plaque composition very carefully and thoroughly, because it has a direct implication, as I said before, in the strategy of treatment. So if you have this lipid fibroateroma with small calcified structures, so you can immediately go for direct stenting without fear of under-expansion of your stent. However, as long as you go to the right, you will see that there is an increasing risk for malapposition. So there have to be other strategy to treat this stenosis in a very good fashion. So there are other morphologies coming along with the acute coronary syndrome. So you have to decide if it's an intact fibrous cup or a disrupted fibrous cup, because if there is an intact fibrous cup, you have a thrombus and there is an erosion. That's a good example for erosion. And in contrary to the IVUS, you can, of course, discriminate the blood and the thrombus very well. You can see here the thrombus without any interruption of the continuity of the intima. So this is a clear erosion of your structure here. In contrary, you have the disrupted fibrous cup, which might be caused by a plaque rupture or a calcified nodule. Just shortly here, the disrupted fibrous cup in the setting of a STEMI. You may appreciate here the tear of the fibrous cap that's protrude into the lumen, into the vessel lumen, and here you have this formerly called necrotic core. It's a cave which is now generated by this disruption and the rupture of the plaque. This is diffusely delineated here and appears very dark. This is typical plaque rupture. So the other kind of disrupted fibrous cup is the calcified nodule, as we just heard. This is the accumulation of nodular calcium with disruption of the fibrous plaque on the calcified plate. It's typically also associated with, of course, a troponin in your blood test. Of course, the acute coronary syndrome can also generated by dissection. Here you can see the spontaneous artery dissection independent from the plaque rupture. As another mechanism. So here, this is extensive lateral and longitudinal plaque rupture can alter, of course, also your coronary flow. You have to discriminate between the medial dissection, which is showing here, from the internal dissection, which not affect the adventitia. So the second step is the PCI guidance, which is a further important step during the PCI procedure. As I told you before, first of all, we have to you can have the co-registration. That means that the angiography is integrated in the OCT, and you can combine this information coming from the OCT with the angio, so that you have the information of your geographics, meaning that you have a precise determination of the region of interest. Firstly, you can minimize the geographical miss, and of course, you can have a better strategy planning if you have this lumen profile as well. So coming to the stent sizing algorithm, it's another very important step. Several approaches, of course, have been proposed so far. I think that the smallest mean EL is the most practical one. So what means the mean EL? You measure the distance from the EM to EM in two regions. It should be orthogonal, so that you have a mean EL of 3.1 millimeter in this example. And then you have, of course, to post-dilate for the proximal reference diameter to allow apposition in this case. If you have here the longitudinal lumen profile, you can well assess the stent length in this lesion as well. These are some examples how to measure your EL distance. Of course, you have to discriminate into orthogonal projection here, the EL. In this case, if you have some atherosfibroma, like in this case, you have in a maximum 180 degrees to measure precisely the EL distance. Of course, in this picture, you cannot measure the EL precisely, so that you have to go distal or proximal to have this correct distance of the EL, which is shown here in the last picture. Finally, OCT can also be used for strategy planning, of course, for example, in the bifurcation lesion. So not only side branch involvement, but also the angle can be determined. Like in this case, this has a crucial effect of your strategy planning, because you have to know what is your angle before you decide to use one or two stent strategies. Last but not least, the post-procedural interpretation and assessment of the OCT. So you have to measure the stent under expansion. This is first of all, you have the relative stent expansion, of course, which should be more than 80%. This means we have to divide the MSE by average reference lumen area. So you divide your stent in two parts, and you measure first the proximal part of your stent, and you go for the reference lumen diameter, and you divide this by your minimal lumen diameter, or you go for the area, then you divide the reference lumen area by the minimal lumen area. You will do this for the proximal part of the stent, and you can do this also for the distal part. And of course, this relative stent expansion should be above 80%. This is the first thing. The other thing is that you have to reach an absolute diameter or area of more than 4.5 millimeters squared, so at least in non-left main lesions. So the clinical relevance of acute malapposition, of course, is uncertain. Nonetheless, I think that extensive malapposition after stent implantation should be avoided and corrected if anatomically feasible. Early strut coverage may be promoted by full apposition, of course. And what is acute malapposition? I think it's more than 0.4 millimeter and a longitudinal extension with more than 1 millimeter. This should be corrected. I will give you some examples. You can see the malapposition of your stent. And of course, this malapposition is greater than 0.2 millimeters. And also, this expansion is unacceptable because it's below 90%. So you have to correct this malapposition. And there's another example where you have this strut malapposition greater than 0.2 millimeter, but the stent expansion is very good in this case. So you can't correct this malapposition because maybe you cannot exceed the stent dimension. So you can, of course, leave it like it is in this way, but of course you have always be aware of huge malapposition after OCT assessment. So another thing you have to correct is the edge dissection, which can also be very nicely detected by the OCT. You have to look at to the lateral extension, which should be not more than 60 degrees, and the longitudinal extension, which should be not more than 2 millimeters. Of course, you should correct this dissection if your TIMI flow is reduced. There's another example for a dissection, an intimal dissection with more than 100 degrees. So this have to be corrected in this case, where in this case only 25 degrees of dissection occurred. So you can leave this dissection as it is, and there is no other stent needed. Another thing after stenting is the intraluminal mass, which is also very important to recognize. You may see that this intraluminal mass maybe not extend more than 300 micrometers. However, there are other criteria which should be recognized if there is more than 10% protrusion of the stent air. So this is unacceptable, and you have to post-dilate in this special situation. There's a practical guidance coming from my good friend Lawrence Reber, which is published in Neurointervention just now. The most relevant target which have to be achieved following stent implantation is shown in this figure. This includes, of course, the optimal stent expansion, the avoidance of the landing zone with a black burden more than 50%, and of course the avoidance of malapposition and dissection, which should be not more than 60 degrees, as I said before, and the extension, the longitudinal extension, not more than 2 millimeters. What does the data tell us? Of course, you are aware of the data, and we all know that OCT is non-inferior to IVUS, so that we can, of course, also use OCT for our interpretation of our BLAC and our PCI strategy. We have no differences in the secondary parameters like MACE and death. However, this was an underpowered study for looking at these parameters. We have some information coming from good registry, which looked at suboptimal parameters like here dissection, thrombus burden, and intraluminal mass, reference lumen narrowing, or malapposition. And if you correct these suboptimal stent deployments, you will end up in a better MACE rate. As you can see here, there's a better target lesion revascularization with a reduced target lesion, and you have also a reduced rate of stent thrombosis, which is not present only at 1 year but also at 2 years. So I think that it's worthwhile to look for these suboptimal stent deployments and you should correct it for. We have also the doctor's data where the investigators looked for the final diameter stenosis, which in an angiographic guided group versus an OCT guided group. And you can see that this was statistically significant in the OCT group, as well as the standard expansion, which was greater after post-optimization with the OCT. If you look at the EFFR measurements in these both groups, you may appreciate that there is a higher FFR measurements after in the OCT guided group. And if you look at the quartiles, if you have an FFR greater than 0.9, so the majority of patients was investigated by OCT. There are another meta-analysis showing very well that OCT is in favor of angiography alone in terms of all-cause death. And finally, we have this nice results from the pan-London PCI cohort, also showing that the cumulative incidence of all-cause mortality is reduced by using OCT. Nevertheless, we have this under-recognized number or underused number of OCT in comparison to IVUS, so that I think it's worthwhile to think about using OCT during your PCI procedure. To summarize, OCT can facilitate PCI procedure in terms of strategy planning and optimization. For assessment of plaque morphology, a stepwise approach should be used, although prospective data are lacking. Tailored treatment strategies based on OCT appear reasonable. PCI optimization assessed by OCT can eliminate malposition and underexpansion, and OCT-guided PCI might result in better outcomes. And it's my privilege to announce that we have now a new release of the OCT Companion, which is distributed by Abbott, so that we can have a look at this OCT Companion. And with this, I thank you very much for your attention.